On behalf of the Learn Study Group, thank you for allowing us to present our work. Childhood trauma fundamentally changes neurodevelopment and centralization of pain. A reorganization of perceptions such as urinary urgency, frequency, and bladder pain can lead to conditions like overactive bladder and bladder pain syndrome. This has been supported by multiple prior studies which have demonstrated an association between lower urinary tract symptoms and sexual trauma. However, sexual trauma is only one of many possible traumas, and there is little literature on the association between all types of trauma and urinary symptoms. Additionally, there is very little literature on the effect of trauma on urinary symptoms in men. Therefore, the aims of our study were to describe the number and type of childhood traumas reported by women and men presenting to specialty care with LUTS, and to describe the associations between LUTS and the number, type, and impact of trauma experiences. Lastly, we wanted to explore whether mental health symptoms were involved in the causal pathway between childhood trauma and LUTS. This was a secondary analysis of baseline data obtained from the Learn Observational Cohort Study, which enrolled 519 men and 545 women from urology and urogynecology clinics over a 2-year period in the United States. Participants were included if they reported at least one urinary symptom based on a 1-month recall period on the LUTS tool. The Childhood Traumatic Event Scale was used to assess traumatic events occurring prior to the age of 17. You can see the domains listed there on the left. For each event endorsed, participants were asked to rate the effect of the trauma on their lives on a scale from 1 to 7. The scale was then summed among those experiencing at least one event to form the Childhood Trauma Event Impact Score. Higher scores indicate a greater number and impact from trauma. LUTS were measured using the LUTS tool, which, as you know, is an inclusion criteria. This tool is validated in both men and women, and the PFDI, with which you are all very familiar. Mental health was measured using the PROMIS items for depression and anxiety and the perceived stress scale. The appropriate statistical tests were performed, and multivariable linear models testing the association between measures of childhood trauma and LUTS were fitted. For each significant exposure outcome combination, potential mediators were assessed to calculate the percent of the total effect of childhood trauma on LUTS that is potentially mediated by mental health measures. 491 men and 520 women completed the CTES and the LUTS tool and were included in this analysis. They had a mean age of 59, 81% were white, and 96% were non-Hispanic. 57% had at least a bachelor's degree. The most commonly reported childhood trauma was the death of a family member or close friend. 25% of women reported a traumatic childhood sexual experience compared to 8% of men. Overall, of the 1,000 participants, 69% reported at least one childhood traumatic event, and 60% of those reported 2 or more. This figure represents the multivariable models which were created to assess associations between traumas and severity of LUTS overall or its subscales. You can see by the error bars overlapping 0 in the first 3 sections that we were unable to demonstrate significant associations between overall LUTS, urinary frequency, or urinary urgency, and trauma. However, in women, the number of traumas was associated with worsening PFDI scores, such that each additional trauma endorsed increased the adjusted average PFDI by 4 points. Compared to those without sexual trauma, participants reporting sexual trauma specifically had worse scores on the urinary incontinence subscale and worse scores on the PFDI. We then performed a mediation analysis to evaluate the percent of the total effect of childhood trauma on LUTS severity. Among those with at least one childhood trauma, 45%, 42%, and 34% of the total effect of the CTE impact score on overall LUTS was mediated by the PROMIS depression, anxiety, and perceived stress scores. This implies that approximately half of the impact of trauma on LUTS is direct, while the other half is mediated by the association between trauma and the patient's mental health. Our study has several important limitations. The CTES is limited to childhood trauma and does not assess traumatic experiences sustained as an adult. Additionally, the demographics of the cohort enrolled in Learn were predominantly white and highly educated, and therefore may not be generalizable when describing rates of childhood trauma or its impact. Finally, the CTES is self-reported and therefore subject to recall and reporting bias. Despite these limitations, we find that childhood sexual trauma is common and associated with urinary incontinence severity, and that the impact of trauma is associated with the severity of LUTS. Similar to prior studies in this field, we found that mental health factors are strong mediators in the relationship between childhood trauma and LUTS. Therefore, the recommendation we can make the strongest is that we could all be more prescriptive about mental health treatment in patients with LUTS and with a known history of trauma. Thank you, and I welcome your questions.